Hello everyone, a very warm welcome on effective digital change. My name's Tim Horton. I'm an Assistant Director at the Health Foundation and I'm delighted you could join us today. In a minute I'll be telling you a bit about the session we're going to have, but before that I'm just going to start with a little bit of housekeeping about how we'll be using Zoom today. So first thing to say is that subtitles are available and you can find these by clicking on the closed caption option at the bottom of the page. There'll also be a breakout group with subtitles. So please contact Sarah Koo in the chat box if you'd like to join that breakout group. We'd encourage you to have your videos on. It's nice to see people's faces. It's always nice, but please have your microphones off to reduce any background noise. A bit later on when we're in breakout groups, we'll ask you obviously to unmute yourself, but if you can remain muted for the moment, that would be great. So in our recent insight survey, Q members told us that introducing digital innovations effectively is a top priority for the improvement community in future, given what we've seen during COVID. And with that in mind, over the next 75 minutes, we're going to be reflecting on and hearing about different experiences of implementing technology during COVID. We're going to be exploring the importance of workforce, system and process design and how they can be brought together with QI expertise when implementing technology. And we're going to try and develop some practical ideas about how to enable effective digital transformation and look where QI methods and tools can be helpful. So it's given me immense pleasure to welcome a very distinguished panel we've got with us today. Ruth Glassborough, Director of Improvement at Healthcare Improvement Scotland. Shanti Vijayaraghavan, a consultant physician in diabetes and endocrinology at Barts Health Trust. Asma Khalil, Professor of Obstetrics and Maternal Fetal Medicine at St George's. And Breed O'Brien, Deputy Director of Digital Health at NHSX. As well as hearing from them, there'll be a chance for some small group conversations in breakout groups later. And there's also going to be the chance to share your thoughts using Slido. And that's how we're going to start to get everyone warmed up and thinking about the theme of today's session. We'd like to ask you a question. So please log on to slido.com and enter the code #A494, which you can see on the screen now. And what we'd like to know is, which one of the following do you think is the biggest challenge for implementing technology successfully? We've given you 5 options here: training for staff and patients, shifts in culture and ways of working, staff buy-in, patient buy-in, and also pressures caused by staff shortages or inadequate equipment. So just take a moment, please, and tell us what you think the biggest challenge of those is for implementing technology successfully. Let's just take a few more moments to allow everyone to vote. So it's interesting, we seem to have a very clear winner, which is shifts in culture and ways of working. And I think that's going to be really relevant to the talk we're going to have today. Now, as we know, implementing technology successfully is a complex endeavour and one that needs to consider a range of factors. We're now going to go to Ruth Glassborough, who's going to talk to us about the importance of workforce, system and process design and how this can be brought together with QI in implementing technology. So without any further ado, over to you, Ruth.
Thank you, Tim, and good afternoon to everyone. The framework that I'm going to share with you today around digital change draws significantly from work undertaken in Singapore. We came across it about 4 years ago, and it was one of those visuals that just immediately resonated with us. And hence we took the model and adapted it into our own context. Next slide, please. So their basic proposition was that if you're going to do digital innovations and introduce new technologies, then you also need to work in parallel on process and system change and workforce redesign. And whilst on the one hand, this is blatantly obvious, our reality was that in practice, that rarely happened. And seeing it so clearly laid out in the framework, well, for us, the penny dropped. We have all these separate change initiatives around process and system redesign. And then separately, we have work around new technologies. And then sitting in a separate silo, we have plans around workforce redesign. And at both a national and local level, these things tended to sit separately and not align and connect. But imagine instead a world where, for instance, the technological developments, we were promoting those to focus on the areas where we have the workforce shortages, or where we were thinking right now in our workforce planning about the technological innovations that are coming down the line and what we need to put in place to retrain and reskill staff, not just to use them, but also thinking about how some of these technologies will result in individuals whose jobs need to be changed, who no longer have a role, and hence we need to retrain them for new roles. Next slide, please. So we added into this, into the middle of it, the fact that every element of it needs to be driven by a focus on the customer or population needs, their assets and their experiences. And this has to remain the central driving force of the change. And then we also highlighted that underneath, the delivery requires the change project to be underpinned by effective infrastructures. Next slide, please. So the original Singapore model also highlighted that QI is important for all three domains. And for us back then, that was a key insight, as there tended to be a tendency to see QI as being mainly the system and process redesign. And I remember having discussions with individuals saying, we're QI, we don't do technology, or we're QI, we don't do workforce redesign. So that insight that actually all of these domains require that discipline around iterative tests of change with data to know whether or not the changes are leading to improvement was really important for us. And for our work in Scotland, we're also highlighting now the need for multidisciplinary change and transformation teams to then take this work forward. Next slide, please. So QI is a necessary but not sufficient skill set for large-scale change, including for change driven by digital innovations. And we need to move away from those constant territorial fights that I'm sure all of us have been in, with each discipline saying that all that needs to happen is more investment in program management, or more investment in QI, or more OD, or more digital specialists, and recognise that we need them all, and that the balance of what is needed will depend on the nature of the change project and where we are on that change journey. Next slide, please. So just to try and bring this model alive, I thought I would illustrate it with a practical example, and one that hopefully most of us can relate to: the introduction of Microsoft Teams across the NHS in the UK to enable virtual working, or it might be Zoom in some other organisations, or whatever your virtual platform is. I'll talk about it in the context of my own organisation, which has been 100% virtual since March. We've had, sadly, no face-to-face meetings at all. I do say sadly, because it would just be lovely to sit in the same room with some folk just even once a month, but I think we're a little way off that at the moment. Next slide, please. So this innovation was actually very much, the success of it has been driven by that population, that focus on population needs, assets and experiences. As we all know, the working from home requirement resulted in a much, much quicker uptake. But in reality, that would not have been possible if it wasn't for the prevalence of broadband, assets that we all brought as staff members to our roles. We've also, as a QI organisation, had to look at how we develop the use of a range of apps, because we're providing all of our QI support virtually. And as well, many of you will know on MS Teams, the frustration of the lack of the breakout room in the way that Zoom does it is really driving the development of MS Teams. So Microsoft have had a very strong customer focus, and you can vote for your latest development. And then interestingly, we can see how the technology is developing in response to the research on the cognitive overload that is becoming clearer and clearer. And Microsoft Teams, as an instance, has a all-together mode that the research shows has less of a drain cognitively. Next slide, please. And so in terms of the underpinning, one of the things we realized from this was we had missed out information governance. It's absolutely critical as one of those underpinning infrastructure issues, but we saw in practice the requirement for the multidisciplinary change teams, the IT, the HR, QI, program management, all working together. And I'm just going to call out this issue of effective leadership, because we have seen that for good virtual working, we do need strong, effective leadership around issues such as attitude to breaks. You can't keep people on a meeting for 3 hours. I heard about one recently that was 6 hours with 2 breaks. And you do require leaders who are able to say, no, we are going to break every hour. There's also that requirement leadership-wise for good virtual working to validate the informal space and find ways of replicating those water cooler moments and saying that is okay for individuals to do. Next slide, please. So in terms of workforce redesign, we have actually seen workforce redesign happening in practice. We've all had to upskill. And as an organisation, we're having to change roles to enable stronger virtual facilitation. Next slide, please. And then finally, the system process redesign. So this is the one where I would question, have we done enough here? Or have we fallen into the traditional challenges of introducing new technology where we just end up digitizing the current processes? And perhaps the challenge I would leave us with is, does the move to virtual working and digitization give us an opportunity to rethink how we run meetings and events in a very different way that is not about virtualizing what we currently do, but is about going back and thinking about the purpose and then thinking about whether or not that could lead us to actually doing things quite differently. So in summary, successful digital change needs to be driven by an understanding of customer needs, experiences and assets. It needs to bring together individuals skilled in QI with those focusing on things such as the practicalities of technological elements alongside a focus on redesign. And I will conclude just by leaving you with that question: are we spending enough time redesigning our systems and processes to maximize the benefit of these new technologies? Thank you.
Thank you, Ruth. It's a great presentation, really clear way of explaining how these elements come together. It strikes me that people are often getting excited about the individual technologies without thinking of this whole set of things that needs to go along with them. And it's a really lovely illustration of that. Now, COVID's obviously changed a lot over the last few months, and it's resulted in the rapid rollout of a range of technologies across the country, particularly technologies for communication and also for health monitoring too. And we're now going to hear from some people about how their work on technology has changed in light of COVID. We're going to hear from Asma Khalil, who developed the Hampton app to help pregnant women monitor their blood pressure at home, and Shanti Vijayaraghavan, who's leading a project to scale up virtual consultations across the NHS. We're also going to hear from Breed O'Brien about her experiences working as Deputy Director of Digital Health at NHSX during the pandemic, and get that perspective from the centre. But first of all, let's start with Asma. Asma, tell us a bit about how your project's been affected by COVID and what opportunities have emerged in recent months.
Well, thank you very much. Thank you for the introduction. Some of the people with us might not know much about Hampton. As you mentioned, Hampton is a platform that enables pregnant women to safely monitor their blood pressure at home. And actually, the initial work was funded by the Health Foundation, and it's one of the NIA or the NHS Innovation Accelerator endorsed innovations. And we, I guess your question specific is about sort of what the impact of COVID pandemic. I think COVID brought actually some big opportunities for digital change and quite swift implementation of digital innovations in NHS. And in fact, I was thinking with your first slide when you had the questions about the challenges, and my suggestion maybe to add an option as an absence of pandemic, or maybe the fact that if you have a pandemic, I think it did have a huge impact on implementation of digital innovations. And so specific to Hampton, I think it's what happened during the pandemic is that the public health message of trying to reduce face-to-face contact with patients to the minimal or the essential appointments. And for those who are not obstetricians or don't deal with pregnant women during the pregnancy, they will have regular visits to see the midwife or the obstetricians. And the purpose of this visit is mainly really one important component. And some of these visits are essentially to check their blood pressure and check the urine and make sure they're not developing high blood pressure in pregnancy or preeclampsia. And of course, for those who actually have high blood pressure in pregnancy, normally these women will come 2-3 times a week just to have their blood pressure in a hospital. So, and therefore having this option of having their blood pressure monitored at home and being able to have a platform that can actually transmit this data in real time to the clinician in the hospital is obviously very popular. So what really happened at that time, a number of things that did really facilitate its swift or rapid implementation, and now it's in about 40 NHS maternity hospitals. And it was more really top-down approach, and of course you need the local champion, the local leadership. But what happened around the first peak is that there was a national guidance. So the Royal College of Obstetrician Gynecologists, around the time of the COVID pandemic, they issued a number of guidelines about how to look after pregnant women during COVID. And they did actually publish a guidance on self-monitoring of blood pressure during pregnancy, which I think is very important, that you have a national guidance that goes through all the various components of implementation and also provides some almost, it's something that the clinicians can actually use. Number one, to say, well, we are following national guidance. And number two, these are the various details of the implementation. The other thing is actually we worked with NHS England, which I think was hugely helpful, is to try to help the NHS hospitals how to reduce this face-to-face contact with the patient. So in fact, there was support from NHS England, financial support, by providing blood pressure machines to all NHS maternity hospitals to provide to pregnant women. And that was really a key component of its implementation. The other thing is that they actually did have a discussion with the providers, including us, and negotiations of how to facilitate its implementation to NHS hospitals, including financially. Also, the providers, the commercial providers, was actually willingness to offer some of the innovation free to the NHS hospitals during the COVID pandemic. And around that time, there were already commercial grants where the commercial providers can apply for, where they actually can use to be able to implement these innovations free to the NHS hospitals. The other thing is that we needed to train the clinicians. So I used to, around the COVID pandemic, and that's something that made me really very, very familiar with use of Zoom, is that I had every weekend a webinar to the healthcare professionals, so with the midwives and obstetricians, about home monitoring of blood pressure in pregnancy, and going through really the details of all the practical aspects of its implementation. So we had weekly webinars, also the community. I mean, there was almost atmosphere of working together and helping each other and sharing experience and how to tackle a pandemic and how to be able to work safely and provide the necessary care to pregnant women. And of course, most importantly, as you mentioned earlier, is the leadership and on the shop floor and having champions. It doesn't have to be a digital clinician or a digital officer or a digital midwife or someone who can just champion it and say, we will need to implement that. What are the challenges? How to tackle it? We don't have slides, but I do have some nice pictures to share with you, and we're actually getting the blood pressure machines and about maybe 5 of us going to actually to get to almost carry the huge number of blood pressure machines and take it to the storage to be able to give it to pregnant women. I think it was a team effort. And as I mentioned, the result is the fact that we do have Hampton now implemented in about 14 NHS maternity hospitals. I'm going to stop here because of the time. I'm happy to take any questions.
To hear how a project that actually, predates COVID has nevertheless been given fresh impetus by it in helping spread. I'm now going to ask the same question to Shanti. Shanti, perhaps you could tell us about how you're.
Thanks, Tim. As people probably know, our team and I at Newham in East London have been looking at online consultations since 2011, initially supported by a grant from the Health Foundation, and then later on with funding from the Health Foundation and the NIHR, and along with Trish Greenhalgh and colleagues at Oxford. And in 2017, the Health Foundation very kindly gave us the Scaling Up grant to roll out online consultations nationally, and we thought we were doing really well. We had 7 services within Barts Health and 3 national trusts we were working with in January, February this year, and we were doing the NHS Attend Anywhere pilot, and things seemed to be cruising along really well. And then come March, and there's this great momentum and rapid rollout of online consultations across the NHS. Which was really quite interesting, as Asma said, nothing like a pandemic to scale up rapidly. So I think what was really quite useful for us was that we worked with a lot of sites across the country in producing guidance documents, SOPs, staff and patient leaflets, and so on. So when it became virtual by default in April for most organizations, we felt that we were able to support people on a scale that we hadn't anticipated. Reflecting on what the big changes have been over the last 6 or 7 months, I think the first thing has been organizational support for us. So where in the past we were working with about 6 or 7 services within Barts Health, and people said, oh, great, this team's doing online contact, but this team really had a lot of workarounds and lots of individual processes within their own department to try and embed non-face-to-face care. The trust itself, like with most organizations, had conflicting priorities. And so the question was, yeah, it's great to do this, but we also have to do A, B, and C. So we'll come to you in a while. But come April, there was no option but to use virtual non-face-to-face contact by default. And so suddenly everything that was a challenge, whether it was working with the IT departments, whether getting SOPs, working with scheduling to get generic templates across the organization, text message reminders across the organization, it just meant everything was being done across the whole organization rather than individual teams working through small standalone processes. So that helped hugely. And if this is going to be business as usual in future, I think this is what was required rather than small workarounds. The second thing, which for me was very important, was that, and it was reflected by the Slido findings, was that it's often a matter of staff perception and clinical staff perception that face-to-face is the default option, and that we do need to physically drag our patients to clinic, even for a routine follow-up appointments. And in the past, we have published and researched a lot about patient perception and co-designing pathways with patients and service users and carers, and people did feel that a lot of this could be done non-face-to-face, but I think a lot of the clinician mindset was around having to bring people to clinic. And in fact, we had said in the past that you needed a prior relationship with the patient to offer online care, and it did help to have initial consultations face-to-face. But of course, come April, and a lot of us were seeing people for the first time online. And actually, I think it did destroy some preconceived myths and perceptions about who you could offer it to, for example, older people, breaking bad news. A lot of this got done online. And so I think it opens up an interesting debate about going forward, what can be done online and what the balance between face-to-face and online care needs to be like. The other thing, a big disincentive in the past was tariff. And there was never a proper tariff for non-face-to-face care. And so financially, a lot of organizations felt the need to bring people to clinic because, of course, the lack of a proper tariff was a disincentive. Of course, now we're all in some sort of a block contract, and it'll be interesting to see what happens in the future. But this getting rid of payment by outcome has helped in some way people innovate and use more non-face-to-face care and look at the patient pathway as a whole. And I think, again, that'll be something to look at going forward. And finally, I think coming back to this whole thing about virtual consultations is just one part of the whole patient pathway. And as Ruth said, I mean, we shouldn't replace what we're doing face-to-face just with virtual and then keep the rest of the pathway unchanged. And I think what COVID has let us do in a funny kind of way is look at the whole way of offering outpatient care and looking at how it might be possible to do things differently. So the fact that we're all having to use electronic records, use various forms of virtual care, interact with different teams in a different way, just means that I'm concerned that some of us might revert to what we were doing in the past. But I think the excitement here is that it allows us an opportunity to redesign outpatient pathways and to look at how we might be able to use all these things that we've grown over the last 6 or 7 months differently going forward, I think. I'll stop there.
Thank you. Really interesting to hear about some of the issues that have been created by the implementation being accelerated during COVID, including around patient experience, tariff, and everything else. Now I'd like to bring in Breed O'Brien, who has been Deputy Director of Digital Health at NHSX, which was the organisation created last year to provide leadership on digital transformation for health and social care in England. Breed, thanks for joining us. What's the perspective you've got from the centre of all of this?
Thank you, and yes, lovely to be here. I probably should start by saying that I started in NHSX on March the 16th, so I had 4 days before it was completely virtual. So that is the view you will be getting from me. It is a completely COVID view. And actually that in itself was really interesting for me because the task I had to do when I first started was to help set up a national blended team to support the rapid implementation of online and video consultation in primary care. And actually trying to do that when you don't know people and you're trying to work completely virtually was challenging. And I would have, anyone who knows me knows that I am very much a face-to-face networking type of person. but virtual has provided opportunities that probably didn't exist previously in terms of being able to reach to people. So I think that supporting some of Shanti's point about perceptions of what needs to be face-to-face and what doesn't is not just about patient care, it's about how we all think, how we operate. As I said, my first task was to set up a blended team. And for me, that was a real reflection of the spirit of team working that I think prevailed at all parts of the system in wave one. So we worked with, I worked with colleagues in NHS EI, the CSUs, NHS Digital and AHSNs, and the blended team was a mixture of all these people. So it was a real team spirit. And alongside that, we had lots of support, offers of support pro bono and otherwise from innovators and the private sector. So everybody got behind, I think, the effort. And I think that's was replicated on the front line. So it was very much the same in the centre. NHSX, when I joined, had already set up their cell structure, which of course was replicated in all the regions and in a lot of organisations. And for me, I was part of the scaling cell, so trying to rapidly scale proven innovation. But I was also part of the clinical cell and the vulnerable and social care cell. And for me, that was incredibly important. So I've got a clinical operational management, QI and informatics background. And you know, that vulnerable care piece for me felt personally very important. And it was reassuring to see the focus in both the clinical, particularly for me, in the clinical and the vulnerable and social care cell. And then it was also what was, I think people in the system particularly appreciated was some of the effort to simplify some things that are quite difficult. So we certainly had lots of really positive feedback on the information governance guidance that was simplified and things like that. So I think that's something to work on, to say how do we simplify some of the things that are quite challenging for people. So I would say a really key observation for me was I saw a lot less of the not invented here phenomena and a lot more of how are they doing that and how can I take that and do it here. So that was a real flip for me, because normally you have people not invented here as an NHS syndrome of old. And a real common sense of purpose. So the crisis, and I think someone mentioned this in the chat, was our burning platform. It brought people together in a way, you know, that hasn't been seen before, particularly around technology. But it did, picking up some of Ruth's points, you know, this was doing tactical things. So the redesign of systems, in a way, some of it has to come later because it was tactical deployment of things. So I think looking forward and thinking about what this has created for us, particularly from the centre, but I think everywhere, is how do we move from that burning platform, and I'm going to quote Peter Fuda, to the burning ambition. And if anything, what we've got is how, and I think this is, both our speakers have said, you know, we've created this opportunity. People have proven that things can be done differently. So we've set about building on some lessons from wave one, where we had really good success with remote monitoring of patients with COVID. And that came about from a clinician asking for help with technology to manage his workload, a respiratory physician. So we have funded a funding opportunity in all 7 regions in England to bid for implementation support funding and license money to support remote monitoring initiatives. And we had a really positive response to that. And all 7 regions are now actively working on this. And I've just actually this morning was on a conference with 150 people in our Innovation Collaborative, and the energy was just fabulous. So I think that burning ambition is there, and hopefully we can continue to build on it. And of course, this is really important about that move from what's traditionally a paternalistic model of care to really enabling patients to self-care, but feeling supported whilst doing it. So really trying to move that forward and support that agenda. And there is just amazing work going on across the system on this. So I wouldn't claim any of it for the centre. It's actually what we're trying to do is understand what's happening on the ground, support it where we can, whether that's with funding or otherwise, and then share, get people to share so we don't replicate and duplicate effort. Really loved Ruth's presentation, because for me, the key is the alignment of QI and digital. People talk about them in parallel. They need to be constantly spoken about together, that common language. And my team is part QI and part delivery, purposefully for that reason. But also remembering that we've been really conscious that digital is not for everyone. So we need to be aware of the digital inclusion and exclusion agenda. But it can work both ways. There's a lovely story, Twitter post from a GP who said, She had just done a great consultation, virtual consultation with a patient who was deaf, because she could actually have the sign language person and she could do that 3-way. So it's inclusive, as we have to just be mindful of both perspectives. But I think shared learning for me is key, and capitalizing on that common sense of purpose and what is our burning ambition moving forward. And certainly that, I think, is the focus from the centre, and really trying to listen to what is needed and respond to that.
Thanks, Breed. It's really interesting to hear, and also exciting that actually, even though much of this recent activity has been stimulated by COVID, your thought that if we get it right, this will actually be part of a broader shift towards more enabling and empowering healthcare. So really, really helpful to hear. Thank you.